record. So you all know it's being recorded so that I can put it up later. I will soon be sharing my screen, and that's what I'm going to do right now. First thing I want to show you is I'm going to do two screen shares. First screen share will be of the page, which is currently which is a blog post actually. It's a blog post that I've set up for this particular talk, and with the link. But I've also, just so you know, I've put download a PDF of the presentation I'm using. So anyone who wants to go there. So it's actually pretty easy. It's breathingclinic.org. And from the breathingclinic.org site at the bottom, there are recent posts. So this is the post here. Okay, so I'm going to stop that share. I know people are still joining, so I'm continuing to sort of look over and let people into the weight room. Now I'm going to share my screen, and I'm going to share the actual presentation. And what I'm looking to see is whether or not I can continue to manage participants and let people in. While running the meeting. Okay, so welcome for those of you who are able to join, and thank you. This is going to be hopefully an hour. We'll end after an hour no matter what. But pulmonary examination evaluation for physical therapists, very basic material, and it's preparation for possible surge situations in different regions of the country. Obviously, I'm not specifying particular examinations for different regions of the country. It's just that everyone in the country is sort of experiencing different levels of outbreak, shall I say, or spread. So there are some areas that may be experiencing surge now. There are some areas that are still in the preparation for surge. And by surge, I mean surge that leads to overwhelming the healthcare system. There is a guideline hopefully coming out soon that started internationally and now is being reviewed in the US that specifically talks about possible redeployment of physical therapists to areas of need, either as part of employment or even volunteer. Like, for example, I'm in New Hampshire, and I happen to know that in New Hampshire, they've got a website called NH Responds, and they're looking for licensed healthcare providers to indicate that they're willing to offer volunteer services. So I want to make a couple of notes. Note, I'm not suggesting that this presentation will equip you for immediate deployment in an ICU. Also, at this point, what I'm hearing is that many locations are not being utilized. I'm not utilizing physical therapists at this point, and that's to minimize the use of PPE, and that's also to limit exposure and risk. I'm aware of both of these points. I do not see those, however, as a reason to not take steps to be prepared. So that's why I'm proceeding with these presentations. I'm hearing a lot of things coming out of social media, and I just want everyone to be aware of the fact that I'm aware of these 2 points, and I still don't think that they are reasons to avoid preparation. And that's maybe one of the reasons you're all here, because you maybe agree with that. So examination links to intervention through evaluation. And so evaluation are the questions that are asked and answered in that process. I'm not going to go into this all too much because you're already physical therapists and you're aware of that. So what I do want to go over though, are what are some of those key questions in pulmonary examination through the lens of what's going on now with COVID potentially. So I've got up here a patient with COVID-19, and the first question any physical therapist would ask before presenting to intervene and to examine this individual is, are they stable? Is this patient stable? And if they're not stable, one of the things that makes a pulmonary patient slightly different than a cardiac patient or maybe other medical condition patients is that with the pulmonary patient, If we say no, they're not stable, there are still possible things for us as physical therapists to intervene on. And so the question you have to ask if they're not stable is, sorry, wait room continues to get people. Is the instability related to airway clearance, positioning, or breathing pattern? And if the instability is related to airway clearance, positioning, or breathing pattern, then you should intervene as appropriate. So these two boxes are things we're going to talk about a lot in terms of our exam. How, in a pulmonary patient, do you determine whether they're stable? And then how, in a pulmonary patient, might you consider whether that instability is related to these three things that physical therapists would be part of intervening for? If it's not related to these three things, and we'll talk about some of the situations where that's the case, then there's a need for medical management. And basically, I should have just said need for medical management, and I should have just looped it right back up to repeat to the question. Once medical management is initiated, then you can reevaluate for stability, or you can wait for the medical management and then reevaluate for stability. If the patient is stable, then we get into a series of questions about whether there's an increased demand for airway clearance. There's a whole bunch of conversations happening right now about whether or not airway clearance is something that should or shouldn't be done. Okay, I'm hearing people say, everyone's got to learn how to do airway clearance so we can go out and do airway clearance for people with COVID-19. It's a virus, and in a lot of patients, the reaction is more of an acute lung inflammation, which would be contraindicated in a lot of those individuals to do airway clearance. So it's not something that's being advocated for all patients. However, I would also not say we shouldn't do it on anybody. Right? I think saying that we would do it on everybody and saying that we wouldn't do it on anybody are the same mistake. So I'm trying to avoid the mistake being made that we do absolute extremism in either direction. And that means sort of being comfortable with how you do your examination, and being comfortable with what your decision is, and being comfortable with what you examine along the way in order to continue to check whether the patient is stable and responding appropriately to whatever intervention you're providing. And incidentally, a week from today, I'll talk about interventions. So if there is an increased demand, then you have to consider whether the patient is active or not. If they're active, then you have to consider whether the activity is enough to promote healthy airway clearance in that person given their demand. So this, I admit, I did this morning for today, and it's probably could be cleaned up a little bit. I've got some people working on it with me now to try to help me clean it up. But for now, I'm going to jump to the next slide, which maybe makes this more easy and makes it a little bit easier. So if the patient is mobile and active, we're here, then you consider, is there an increased demand for airway clearance? And if there is an increased demand for airway clearance, then you need to determine whether mobility and activity are effective in this person to maintain effective airway clearance. And you need to consider pre-existing pulmonary, neuromuscular, or orthopedic reasons, because these are reasons that would lead to the mobility and the activity to not be effective for increasing the demand, whether it's be that they have more mucus or impaired airflow, whether they have weak expiratory muscles or improper inhalation because of a kyphoscoliosis. So there are multiple sort of other body system reasons for someone to be active, but in a limited way and with poor clearance that you may want to consider if they have that increased demand. And essentially, you're going to track pulmonary status to see whether their activity is keeping up with the demand they have for airway clearance. You all have a baseline demand for airway clearance. You basically just swallow your mucus every day because there's not a huge demand for it. It's very similar to the demand supply consideration of lymphedema, lymphatic system. If they're mobile and active and they don't have a demand for airway clearance, there may not be a need for PT intervention. And to be honest, this is probably the majority of people with COVID-19. So I just want to point that out. Estimates I've seen are that about 34% or so of people might be in this row of needing airway clearance, but the majority are down here, and the majority aren't sick enough and they're able to keep moving around. This might be, I'm not saying it is, but this might be one of the reasons that younger active people are not getting as sick because they're able to stay mobile enough that they're keeping their airways healthier. It's pulmonary hygiene just by moving around. So if they're not mobile or active, they're bedridden because of how sick they are. If they don't have increased demand, well, this is called physical therapy, right? It's you consider the reasons they're not mobile or they're not active, and you intervene as appropriate. If you can get them, if they can be mobile or you can get them mobile and active, then you want to do that, and they move over here. As soon as you can get them mobile, they're now in this quadrant. If they cannot be mobile or active, intervene, then you intervene as appropriate for mobility. This is physical therapy. So this here is probably the most significant need. If they're not mobile and they're not active, then there may be needs for airway clearance if they have that high demand, and there are definitely needs to keep them mobile and active. And this is where you may be, as if you're a redeployed therapist to a healthcare system, you're probably not the person they're going to put into the ICU getting someone in this quadrant up and moving for the first time. So it really, I'm sort of trying to speak to a wide range of potential audience members. And I have to point out that I'm really sorry, but with the big screen, I've sort of lost the ability to see the chat. And if I can bring it back, I will, but I'll pause in a little bit and look to see whether there are any questions. So previous. Okay, so I had that twice. All right, my rationale here is probably just that once you see the quadrants, this might make more sense if you revisit it on your own. Okay, so the relevant questions, relevant evaluation questions for a presentation. So we're assuming here an acute care facility after a COVID-19 diagnosis or suspicion. So the questions are, is this patient stable? Is instability related to airway clearance, positioning, or breathing pattern? Is there an increased demand for airway clearance? Other questions that we're not going to focus on as much are the considering physical activity along the way. And then is there an endurance limitation will be a question for future sessions, particularly sessions I'll do on early mobility and ICU mobility. If anyone's looking for a review on that, probably a little bit more advanced than this talk. So it comes down to three foci: stability. What does it mean for pulmonary function? Airway clearance, specifically demand capacity, and how to examine or consider airway clearance as a function. And mobility, particularly whether it's effective in the case of needing airway clearance. So this is where that falls in the broader algorithm of, is the patient stable and is the stability related? Once again, to point out that unlike many patient populations where we would answer the question, is this patient stable? And we would say no, and we would walk away and say, oh, not my job. For the pulmonary patient, sometimes it is your job to be involved should there be instability. And that's in the case of airway clearance, positioning, or breathing pattern. So stability is a dynamic systems concept. It's about achieving homeostasis. Can we attain homeostasis? And I imagine if I were to ask the question, you would all say homeostasis of the pulmonary system is essentially looked at the most basic level as oxygen and CO2 levels. And you would be straight up correct. We could go beyond that and say oxygen and CO2 and pH. We could go beyond that and say oxygen and CO2 and pH and bicarbonate levels. So these are levels that are typically maintained within a fairly tight boundary, literally the definition that Walter Cannon used for homeostasis, these tightly bounded conditions. So being able to maintain homeostasis during perturbations and variations. So stability is not just achieving it, but it's maintaining homeostasis despite the fact that you ran up the stairs in order to keep your oxygen high and your CO2 low, you breathe heavier. That it allows you to sustain that homeostasis. So if somebody can attain stable oxygen levels, we need then to consider whether they can sustain those levels under different circumstances. Therefore, it's a dynamic systems concept. So this is the pulmonary function as a dynamic system. We're considering ventilation, which is the movement of air, bulk flow, breathing in and out. Total ventilation is what provides alveolar ventilation. You can have total ventilation in different patterns that will lead to variations in alveolar ventilation. So the relationship between total ventilation and alveolar ventilation, while linear, is not perfect. It's not a correlation of 1.0. There's variability there, because if you breathe really fast and shallow, like really shallow, then you'll have a high total ventilation, but not necessarily high alveolar ventilation. Breathing patterns. So the way you are breathing, the mix of rate and depth, and whether it's low lung or lower lung, diaphragm or upper lung, that influences your movement of bulk flow, and in a little bit also of your alveolar ventilation. And then posture and position. So here I'm going to try to stick with the convention that posture would be, you can have multiple postures in different positions. Positions would be standing, sitting, reclining, lying down, supine, and then postures would be anteriorly pelvically tilted in the supine position, or anteriorly pelvically tilted in the prone position. Respiration, moving, is another pulmonary function, and it's moving of gases. So when we talk about respiration, we're talking about diffusion or gas exchange. In fact, I have this tremendously bad habit of essentially just using those terms interchangeably: respiration, diffusion, or gas exchange. But respiration is influenced by alveolar ventilation. See the connection right there? It's the connection. Alveolar health, meaning you can have plenty of alveolar ventilation, but if every one of your alveoli has reduced surface area and is thicker than normal, then through Henry's law, you could figure out that respiration is going to be impaired. That it's not just about getting air into the alveoli, it's the surface area for diffusion, and it's the thickness through diffusion. Pulmonary blood flow to the ventilated alveoli is, and this essentially, I'll refer to the topic later as ventilation perfusion matching, that you can have all the ventilation in the world going into your alveoli, but if there's no blood flow going there, then you don't have respiration. And the blood flow and the ventilation is actually influenced by position. So we're not going to talk about the physiology of why there are changes with position changes. I think for people in illness situations, knowing that pulmonary blood flow and alveolar ventilation they're both influenced by position, means that you may, in a trial and error way, try different positions to maximize respiration. So often, a very common tried position for people with acute respiratory distress syndrome, which is a condition that is not necessarily amenable to airway clearance, but is to positioning, is prone positioning. Sometimes people, they have better respiration because of the distribution of ventilation and blood flow, pulmonary blood flow, when they're in that prone position. So if you've heard anything, if you've been looking around online for what are they doing with people in the ICUs with these critical lung conditions, sometimes PTs are involved with the process of trying different positions, and that might involve trying prone as a position. Okay, so the essence of this dynamic system of pulmonary function, of ventilation and respiration, is that ventilation enables respiration. If you don't ventilate, you can't respire. And respiration controls ventilation in a few different ways. Literally, our chemoreceptors are the strongest determinant of how much we ventilate, and they respond to the product of respiration. So they respond to O2 and CO2 levels. So that's what I mean by respiration controls ventilation. Another way is that ventilation is entirely a muscular activity, and muscular bioenergetics can't happen without respiration. Without oxygen to the cells, then you have limited ability to sustain muscular activity, and that includes ventilation. So respiration controls ventilation through the nervous system, but also through bioenergetics. So this kind of noisy, so I'm not going to spend a tremendous time on all these noisy slides, but I put this together today. It's kind of an amalgam of old slides that I've had. We're going to start with, ventilatory demand influences breathing pattern. Breathing pattern, if you have ventilation problems. So this is not a causal map. This is sort of like a flow concept map. So I'm still letting people in. For those of you that just joined, I'm really sorry that it took me so long to notice you were there. I see a chat. Okay, so you might have joined later. I'm going to be coming. My opinion of sidelining to improve ventilation is that I would try it. And if it improved ventilation, I would be happy with it. And if it didn't, I would try something else. All right. So that's good to know that I actually can see if there's a chat. If I go up. All right. So ventilation problems, they can be inspiratory problems, restrictions leading to hypoinflation. And this pneumonia, which is one of the responses to, in the more severe cases of COVID, is pneumonia. We get hypoinflation, and we get essentially this restrictive condition, and that impairs alveolar ventilation. If people have underlying obstructive lung conditions, so as far as I know, COVID-19 is not causing the kind of airway responses that we would see in bronchiectasis or chronic bronchitis, where we're thinking about it as a primary obstructive condition. But just if someone has a baseline obstructive condition, then they could have some hyperinflation, and that hyperinflation is going to alter chest wall mechanics and reduce inspiratory muscle force. And that's going to affect breathing pattern, but it's also going to lead to further hyperinflation. And ultimately, this hyperinflation is going to reduce alveolar ventilation. When we start thinking about alveolar ventilation, other factors include alveolar inflammation or mucus, also includes postural implications of alveolar ventilation and the distribution of alveolar ventilation as we change positions. So distribution of alveolar ventilation, if it's evenly distributed, if there are abnormal, just evenly distributed abnormalities, then the main impact is going to be on pressure gradients, and it's going to affect O2 and CO2 levels. If it's unevenly distributed, then it's going to affect more of the VQ matching, and it's probably going to have a bigger postural influences will be stronger. So that's why, if we don't know, you could try positional changes and see if they have an effect. And if they do, it may indicate they have more VQ matching, but at that point, we're not necessarily worried about why. It just showed it was effective. My main point for showing all this is that we come right down to O2 and CO2 levels. And we are considering ventilation patterns. We're considering position. We're considering the presence of airway inflammation and mucus, which can affect airflow. And we're considering alveolar inflammation or mucus, which can affect alveolar ventilation. Now, O2 and CO2 levels is going to affect activity, and activity is going to affect ventilatory demand. Technically, I should also have a line from O2 and CO2 directly to ventilatory demand, because it doesn't just work through activity. So sorry about that. I'm going to stop the share, look at the chat, ask whether anyone has any questions up to this point. I know I'm moving fast. I have a lot more to get through. All right, I'm going to go back then. I'll give it 10 more seconds just in case people are typing. I want to frustrate them by disappearing before they type. Okay. Back to the PowerPoint. So ventilation and respiration, this is sort of like a sidebar, requires a function that we could call bronchopulmonary hygiene. It's essentially air moving in and out of your lungs, but also the mucociliary escalator or elevator or mucociliary function, the presence of a little bit of mucus that can trap dust particles and move them up the airway. And in most situations, you swallow them without even noticing it. And if it becomes greater and greater in volume, you find yourself having to cough up mucus. Airway clearance is the ability to clear those airways when substances need to be cleared. So they are both functional tasks. And activity, mobility, and movement supports healthy bronchopulmonary hygiene and airway clearance causally. And they're also associated with healthy bronchopulmonary hygiene and airway clearance. So it's sort of complicated in that there's a causal relationship that activity, mobility, and movement would improve bronchopulmonary hygiene and airway clearance, but they also tend to be associated with it, which might inflate that causal association a bit. And here's what I mean by that. There are some circumstances where healthy individuals, people who can move and move a lot, still have challenges with airway clearance. So just sort of keeping that in mind. So pulmonary assessment tools. So this is a flashback for some of you to your early days of PT education. We're going to talk a little bit about pulmonary function tests and how they are primarily an assessment of ventilation. There are some pulmonary function tests that I won't talk about, particularly the diffusion limited carbon monoxide test, which assesses respiration. But the airway the movement of air that is typically thought of as your traditional pulmonary function tests, such as the forced expiratory volume in 1 second, is a measure of ventilation. A chest X-ray is primarily a measure of how much air is getting into the airways. Now, if you see that not a lot of air is getting into the airways, into the lungs, based on consolidations on chest X-rays, then it certainly speaks to a likelihood of impaired respiration because of that lack of alveolar ventilation. Arterial blood gases are a direct measure of the effectiveness of respiration, and therefore considers ventilation. And that's why if someone has hypoventilation, it may appear as elevated CO2 in respiration. But for the purposes of our examination and for the purposes of our interventions, it is still important to keep these two functions of the lungs, ventilation and respiration, somewhat separate in our mind for how we examine and then subsequently how we intervene. SpO2, oxygen saturation. Incidentally, SP, little p, that's the abbreviation for oxygen saturation, which is S little AO2, as measured by a pulse oximeter. So SpO2 is oxygen saturation measured by a pulse oximeter. S little AO2 is an actual lab test of how much oxygen is bound to hemoglobin. Lung sounds are an assessment of ventilation. Ventilatory muscle strength is an assessment of ventilation. Breathing mechanics is related to ventilation. Breathing patterns, ventilation, and potentially respiration. For example, gasping for breaths or certain types of breathing patterns tend to be associated with altered respiration that's causing that altered breathing pattern, which is why I like to kind of just keep breathing patterns in mind for both. Now, just because some people aren't necessarily familiar with the different, using the terminology breathing mechanics and breathing patterns, so they tend to clump those two things together. So for my purposes today, or whenever I teach this, mechanics is essentially the question, can they use their diaphragm? Can they use do their ribs work normally? Do they have the musculoskeletal system for changing the volume of the thorax? And then breathing pattern is how they actually do that. So, sort of the little version of it is mechanics is, can they use the diaphragm? And patterns is, are they using the diaphragm? So I've seen several people who can use their diaphragm, but they don't use their diaphragm. So they have good breathing mechanics, but they don't have good breathing patterns. So stability, achieving stability. The three things I would recommend for considering whether stability has been achieved: is this patient stable? Are arterial blood gases, SpO2, and breathing patterns. So arterial blood gases, partial pressure of oxygen. I'm not going to spend a lot of time here on the breathingclinic.org website. If you go to the post, the blog post on this session with the presentation up there as a PDF file. This is a live link. If you click on that live link, what you'll find is a YouTube video of me talking for 17 seconds on how to interpret arterial blood gases. So you're more than welcome to do that. And in that, I also talk you through the process of figuring out respiratory acidosis with metabolic compensation versus respiratory acidosis without metabolic compensation. And why that's important is it gives you some idea of whether or not this person's current respiratory status is acute or not acute. So if they have respiratory acidosis without compensation, then you could consider it a relatively new finding, a new state of being, not their trait, not their general characteristic. But if they have respiratory acidosis with metabolic compensation, which can take 8 to 24 hours to occur, then because of the fact that they've got the compensation, you know that it's not as acute of a situation. So if you have a relatively normal pH and you have elevated CO2 and elevated bicarbonate, then that's an indication of respiratory acidosis with compensation. And the fact that they're compensated means that, you know, something's not right, but it's kind of been there for a little while. And that's where the patient history and other factors kind of fill in the story for you. So there's a relationship between SpO2 and the blood gases, and the relationship is specifically between oxygen saturation, SpO2 here on the y-axis, and the partial pressure of oxygen. And for arterial blood gases, this PO2 would have a little a, but I pulled this image off of Wikipedia because it was Creative Commons and I could use it without being sued. Incidentally, everything in this presentation is there's no copyright infringement. So the important feature of the relationship between oxyhemoglobin or oxygen saturation and PO2 is that the zone of hypoxia tends to be around an SpO2 of 88 to 90 and a PO2 of 60. So if someone starts to become hypoxic, and I'm going to use the words carefully here, if someone starts to have hypoxemia, where they don't have enough oxygen in their blood, it tends to be that they're down in this range here. So it could be that someone has drawn blood and assessed their partial pressure of oxygen. It could be that they had oxygen saturation measured. So at the bedside, you're measuring oxygen saturation. Pulling off an arterial line or from an arterial blood draw, nurses, physicians are assessing blood gases. If you see that someone's blood gases are in the 50 to 60 range, with whatever oxygen they're being delivered, then you expect their oxygen saturation levels to be in the 85 to 90 range. So it's sort of an expectation, and that person probably would not be considered stable right now, that they're going to be doing interventions to try to get their oxygen levels higher, whether it be non-invasive mechanical ventilation, which at this point I think they're saying is probably not indicated for COVID. They're going right to invasive ventilation if that becomes necessary. Now keep in mind the decisions for the ventilation decisions aren't limited just to blood gases, because supplemental oxygen will bring someone up. So if you saw that they came into the hospital with a blood gas of 50, but now you're recording an SpO2 of 95, you'd probably see that the blood gas of 50 was without any supplemental oxygen, and the SpO2 now of 95 is with supplemental oxygen. So that's something that would change with supplemental oxygen. So this can be considered a very dynamic range, but stable would be considered above 90%. Above 88%. All right. Breathing pattern. So you have to consider the breathing pattern in light of the blood gases or SpO2. I think I'm going to drop right down to the take-home message here, and it's how hard is someone working for that level of stability. So if somebody has an SpO2 of 93, but their respiratory rate is 30 breaths per minute, and they're doing so as deep as they can, and they're doing so through an open mouth, essentially gasping for breaths with accessory muscle use and diaphragm use with huge excursions of the chest wall, well, that might not be considered stable, right? So the interpretation of stability based on blood gases and SpO2 isn't just based on blood gases and SpO2, it's blood gases and SpO2 in light of the breathing pattern. So if they're maintaining oxygenation and a reasonable pH and a reasonable PCO2 or normocarbia, normal carbon dioxide levels, but they're fighting to do that, then they're probably not stable because that's not something they can maintain. It's essentially, they're sort of just working quite hard. Other ways you could consider how hard they are working with that breathing pattern probably would be vital signs, so heart rate, blood pressure, or other sort of indications. Indications of dyspnea, so reporting dyspnea levels through various tools that are available for assessing dyspnea levels in individuals. But the main point here is that you're always in the assessment of that first question, are they stable? Then you're thinking about the end goal of pulmonary system is getting oxygen in and getting carbon dioxide out. And even if they are doing that, you then have to consider the breathing pattern and what is the breathing pattern that's behind that finding, that oxygen level. So, and this is kind of like overlaps into can this be sustained? So if they are stable, they have a pretty good breathing pattern, but they also have and they have pretty good blood gases, pretty good indications of respiration, then how long can this be sustained? And that's where other measures like pulmonary function tests, is there an underlying impairment to their ventilation? Their chest X-ray, is there anything, have routine repeated chest X-rays showed progress? And to me, in my time in the intensive care unit, what this essentially meant was we would be going back more frequently. So even if someone was stable right now, we might go back more frequently if there are indications on the chest X-ray that things might be deteriorating quickly. Lung sounds are as an indication of whether or not there is a not yet unstable, but progressing toward instability. So lung sounds, including absent sounds, obviously are very, very bad. Crackles or rhonchi. And in the lung sound section of the presentation, I have a link to something called the auscultation assistant. So ultrasound imaging, yeah, absolutely. This is a basic introduction. So if that is, I think, using an ultrasound to assess pulmonary edema is wonderful. I think in most of these settings, they're going to be using chest X-rays. If we're sticking with the acute care setting, they maybe will pull out an ultrasound. I don't know if PTs would be the ones pulling out the ultrasound in these settings, but maybe, and it's certainly something I would consider at this stage in our profession, probably more of an advanced approach to examining pulmonary function. But yeah, thanks for bringing that up. Ventilatory muscle strength. If they have extremely weak ventilatory muscle strength, then that is something to consider. And in this hour presentation, I'm not going to be able to go into too much detail on how to assess ventilatory muscle strength, but I can give some suggestions for further look. But if you looked up testing inspiratory muscles, you would see a whole slew of YouTube videos and links. There's been much more research on inspiratory muscle strength or even expiratory muscle strength than there has been actual clinical practice. But it's certainly something to consider assessing or considering in the ability to sustain stability. And then, of course, breathing mechanics. So, for example, somebody's breathing pattern may be using quite a large amount of their possible breathing mechanics. So the ability to move their chest wall might be, their current use of chest wall range of motion might be approaching their limited ability for chest wall motion. And if that's the case, then can they sustain stability with activity? Maybe not, because at rest, you're using a large proportion of that range of motion, usually assessed. I mean, it can be assessed with just a tape measure, but also hands on chest, anteriorly, posteriorly, seeing how much movement there is, and assessing the movement they're doing at rest compared to the movement they do during maybe a full breath. So you could either have them breathe in completely, track the movement with your hands, and I'm obviously exaggerating here, unless you've got some, I'm exaggerating. And then as they expire, you track how much motion you saw. There are tools out there. One of them is called MARM, movements, MARM, I believe it is. And you essentially, I don't know if people can see me, but you're putting your hands on their lower rib cage posteriorly, and as their ribs move, you're watching how far your thumbs move away from the spine as an indication of how much movement there is. So if someone is at rest, moving quite a bit compared to their max capacity, then that's an indication that they maybe can't, they don't have a lot of buffer or a lot of wiggle room or sort of extra space, essentially, to move air in and out. So pulmonary function tests, the most popular pulmonary function tests are the FEV1 and the FVC. So here's a sort of classic COPD versus normal. I haven't seen it. I haven't had a chance to look yet to see whether anyone's done any PFTs. But I'll talk about this pattern, and then I'll explain a restrictive pattern, which maybe is more in line with what someone with pneumonia based on COVID might present with. So, and this is probably going to ring bells to you, because this is one thing that's certainly covered in cardiopulmonary classes all across the country. Pulmonary function tests include taking in air to total lung capacity and then blowing it out as forcefully as you can. So the F for FEV1 and for FVC is forced expiratory volume, forced vital capacity. So it's a forced breath. And under normal circumstances, you get most of that air out in the first second. And then you get the remainder of that air out over the next 4 to 6 seconds. So we see under normal circumstances, 80% came out in the first second. But with an obstructive condition, only 60% came out in the first second. So there's a reduction in the FVC, but the reduction in FEV1 is more severe. If this was a restrictive pattern, and this just happened to be the picture I had available that I didn't have to ask permission for, if there's a restrictive pattern, then it would be the same slope, and we would still get 80% out in the first second. It would just be that the FVC would be tapered. So we might see the same FVC of this person with COPD, but 80% of that value would have come out in 1 second. So restrictive conditions, essentially, there's a reduced ability to get air in and to fill. So there's reduced alveolar ventilation, but you can move that air in and out without a problem. So air is moving in and out without a problem. Now, the nice thing for airway clearance with a restrictive condition is that the ability to move air out rapidly is a strong and important part of an effective cough. If you want to cough effectively, you've got to rapidly move air out of the lungs. So the reason a low FEV1 and a low FEV1 FVC ratio is a problem for people with these underlying lung conditions that might be getting COVID is that if they have a mucus-based or an airway clearance need with COVID, then they're going to have a much harder time getting the mucus out because they have limited expiratory airflow. And that's the main take-home message here. Here are categories of mild, moderate, severe. This isn't about COPD, so I'm not going to stop here for very long at all. If someone does have a form of obstructive lung disease as an underlying condition, and again, I'm pointing this out because we're talking about surge, we're talking about people getting really sick and needing hospitalization. That's a relatively small proportion of people with COVID at this point. But if they do, the people who already have pulmonary diseases are more likely to be those people. And so if they have that hyperinflation, there can be an irreversible component to it, which is the barrel chestedness that you may remember or have familiarity with. And then there's a reversible or dynamic hyperinflation that occurs. Either way, one thing that might be newer to you, depending on when you went to school, is this Hoover's sign. Hoover's sign is essentially lower thoracic paradox. It means the lower thorax is not doing what we expect it to do. It means that the lower thorax is pulling inward during inspiration. So if somebody has Hoover's sign, where the lower rib cage pulls inward during inspiration when it should be moving outward, then it's an indication that mechanically their diaphragm isn't working very well. And it's actually working sort of against taking a good breath in. And that is a sign of quite severe hyperinflation. Again, this is an old presentation that I've retroed for today. So here is some slides from showing the dynamic hyperinflation of people with COPD, quite severe dynamic hyperinflation of basically like a half a liter, which is 500 milliliters, which is quite a lot of air being held in the lungs after exercise compared to normals, who some people have a little bit, but most people don't have any. And this is something called dynamic hyperinflation, which is the #1 reason with people with obstructive conditions we teach pursed lip breathing. And the effectiveness of pursed lip breathing would be evaluated through whether or not it mitigates dynamic hyperinflation or not. Another example of that, it's in the presentation, hypoventilation. So just first thing about hypoventilation, it can be caused by hyperinflation. So if you hyperinflate, you will hypoventilate. Let me just slow that down a little bit. If you continue to take more air in than you can get out, then your residual volume increases, and then you can't take as much air in because you haven't gotten as much out. Or it can be from restrictive processes. So your traditional restrictive processes include interstitial lung disease, pneumonia, lung masses, pleural effusions, acute lung injury, which causes lung inflammation, is sort of pneumonia and acute pneumonia and acute lung injury are the acute severe phases, are part of the acute severe phase of COVID-19 from what I'm hearing and reading. So breath sounds. I think I'm going to refer you to the link. What time is it? Definitely going to refer to the link on the breath sounds. Thank you to my colleague Tracy Houle for letting me use her slides. So normal movements of the chest wall, the lower rib cage, is that bucket handle motion out to the side, and it's associated with diaphragm function. The diaphragm drops, but while the diaphragm's dropping, it's also pulling up on the lower ribs. As it pulls up on the lower ribs, because of their joints in the costovertebral joints, the movement tends to be outward in a bucket handle motion. So it has to do with that zone of apposition between the diaphragm, which does go down, but it also pulls the ribs up. Because as you know, when muscles shorten, they just simply shorten. They pull from both ends. So as the diaphragm shortens, it drops, but it also pulls up on the ribs. As it pulls up on the ribs, they move out to the side. So that's a normal motion. You can just feel that with your hands. You can measure that with a tape measure. Paradoxical movements are any movements that go opposite. So we expect lower rib cage to move out and the upper rib cage to move out with a full deep breath. If the rib cage moves in during inspiration, or if the abdomen moves in during inspiration, that's a paradoxical movement. That's going in the opposite direction. Accessory muscle use, it's under normal circumstances, it shouldn't be present at rest. Yeah. I'm glad the chat feature is letting me know. All right. I don't know whether visceral mobs would be helpful here. I don't know at all, and I certainly don't know in COVID. I've heard about chest wall motion and maybe even lung volume being assessments people do when they are involved with visceral mobs, but I personally don't know any of the research. I'm super interested in whether there's research on the influence. I know that several of the abdominal wall muscles are critically important. You know, even sort of like quadratus lumborum are important in terms of their having attachments to the diaphragm. So I know that the movement, the ability of the diaphragm to move is greatly influenced by those muscles. So they're very well if those visceral mobs are helping to loosen up scar tissue that is essentially limiting motion of the abdomen, and through the abdomen, its superior wall, of course, is the diaphragm. So it certainly makes mechanistic sense. I'm a realist, not a pure empiricist, so I would sort of be super interested in anecdotal case reports or studies on that, but because I think it would be worth pursuing, because there is certainly a rational foundation for those being helpful, for sure. Yeah, so measurement, palpation and tape measure would be my preferred. Hoover sign's fine. It's really just something you note that it's there or it's not there, though, right? Hoover sign, again, being the paradoxical movement of the lower thorax. It's either there or not there. So it's not it's you know, dichotomous. It's not really super helpful as a measurement, but it's important to note if they do have it. Ventilatory muscle strength, so maximal inspiratory pressure, or MIP, maximal expiratory pressure, or MAP, are the two most utilized. Now, you may also hear respiratory therapists, or you might hear talked about out there sort of a negative inspiratory force. Negative inspiratory force is also assessed. I think there are different ways of doing so, and so I don't want to talk too much about that. MIP and MEP are isometric tests. They're really like sort of manual muscle tests. But the positions, let's talk about the positions. Maximal inspiratory pressure position is at residual volume, which means the person blows all their air out and then tries to inhale with a pressure device. There are numerous different pressure devices out there, and I would encourage you to sort of look those up if you have any interest in doing some maximal inspiratory pressure measurements. Maximal expiratory pressure is not something I would advise testing in someone who you suspect no problems with cough strength with. If you have a weak cough, if it's not related to airflow problems as measured by PFTs, then you may consider maximal expiratory pressure and a strengthening program for maximal for expiratory strength. A strengthening program for expiratory strength is basically a core strengthening program. Anyone who has ever been sick and coughed a lot, you probably got the best core workout of your life. So a good core workout strengthens your cough. So the reason I don't like to test it, I don't test it in students because I don't want any of them sort of blowing their eyeballs out of their skull as they try to beat each other in the highest maximal expiratory pressure. You know, it's basically the most forceful Valsalva maneuver you could try to do is what it is, which I try to avoid if I can. It is possible to measure ventilatory muscle endurance. It's definitely harder. It includes more expensive equipment. And there's a strong relationship between ventilatory muscle strength and endurance. Breathing patterns, so VE is ventilation, VT is tidal volume, RR is respiratory rate. So there is a pattern and balance of tidal volume and respiration that influences alveolar ventilation. So if someone is breathing rapidly and shallow, they will have less alveolar ventilation for every given volume of air being moved. So if you're breathing 6,000 milliliters and you're doing so by breathing 20 breaths a minute, you're not going to get as much alveolar ventilation than if you're breathing 6,000 milliliters and you're breathing 10 breaths per minute. You'll get more alveolar ventilation with the slower pattern. So this is why if someone if you determine someone is actually not stable, but it's related to their pattern, and their pattern is related to anxiety, and their anxious pattern is causing them to breathe rapid and shallow, and that's elevating, that's resulting in altered CO2 levels and not as effective respiration, then helping that person assume a slower, deeper respiratory breathing pattern may be helpful. So how do you assess the influence? Ideally with oxygen levels and patient report and watching their breathing pattern. And if you had access to it, it would be wonderful to be able to do CO2. If you don't, most people aren't going to have access to these, but there are devices that go into your nose and have a little pump, and they sample air, and they tell you what they estimate CO2. It's capnography. It estimates end tidal CO2. So is stability impacted by airway clearance, position, or breathing pattern? One thing you're considering for airway clearance is their cough strength and productivity and the presence of mucus. And what I decided in going through this talk and preparing this talk is that at this stage, I didn't want to go too much in and say too much, not knowing who was in the audience, about the evaluation of the presence of mucus, given the fact there are situations with COVID-19 that it would, if they have a lot of pulmonary edema related to airway inflammation, airway clearance would be contraindicated, or at least strongly advised against, because it's not mucus, it's inflammation that should be dealt with medically. And another consideration is if you think there's mucus and it's not mucus and you have them doing a lot of coughing, then the transmission rate increases, because these techniques do tend to lead to more of the virus being coughed out when they cough. So I think that if you're being redeployed and you're in these settings and you're involved, I think, and you really are being asked to consider whether that you need to help with airway clearance techniques, I don't think you should be afraid to ask them, physician and nurse, whether or not they think, or a therapist with more experience than you, whether they think there's mucus, and whether or not your intervention should include airway clearance, or whether that's something to avoid at the time being. But certainly, if there's a suspicion of airway clearance being a factor, then seeing whether they have a strong cough, and if it's strong, seeing whether it's dry or whether it's wet, and whether they're productive. Seeing mucus come up with a strong productive cough is sort of an indication that there is mucus. Having them on their own cough effectively and move around more to enable more coughing and deep breathing is a very appropriate, probably the first line of action would be to try to use their own activity levels and mobility levels to provide the healthy, normal bronchopulmonary hygiene and the airway clearance. With pulmonary function tests, you're considering whether there is effective expiratory airflow. Again, that's going to be related to cough strength. If there's really poor pulmonary function tests, then chances are you're not going to have a strong cough. You're going to have maybe a forceful cough, but you're not going to have good airflow, and it's potentially going to sound very tight, maybe even wheezing while they cough. Chest X-ray gives you an indication of the radiologist or physician reading of the chest X-ray can help you figure out whether or not you've got mucus related to pneumonia, or whether you've got airway inflammation related to an inflammatory process, or whether you've got pleural effusions. And someone earlier mentioned the potential use of ultrasound to help determine whether there's pleural effusions. Again, because pleural effusions, if you remember, it's not in the lungs, not in the airways. Pleural effusions are in the pleural space. Blood gases and SpO2, are there changes with position or changes after mucus production? That's indicative of whether stability is impacted by these factors. Lung sound changes with mucus production or cough. Is ventilatory muscle strength strong enough? And is the diaphragm an option? And if so, are they using it in terms of breathing pattern and mechanics? So the second half is sort of what we just, here, increased demand for airway clearance. I'm just going to bring us at here. Is there an increased demand for airway clearance? If there's a presence of mucus and their cough is strong and they're active, then you're basically just tracking, someone's tracking to make sure that they're continuing to be effective at clearing their own airways. So let me just do that stream of thinking one more time. If someone has mucus and they have a strong cough and it's productive and they're active and mobile, then whether their activity is meeting the demands is you're essentially tracking them across time, or even someone's tracking them across time to make sure that there isn't a deterioration in what? A deterioration in everything we've already talked about. A deterioration in respiration, blood gases, SpO2, breathing pattern, lung sounds, chest x-ray. If those start deteriorating, then clearly their activity isn't keeping up with the presence of mucus. So what I'm saying is if they're here, you're paying attention to whether they're going over here. It's not that they're not mobile, just really, I guess you'd say not mobile or active enough, or the efficiency of mobility and activity. Again, most situations where airway clearance, most situations are here. There isn't a demand for airway clearance because there isn't an increase in mucus. If they are in this mucus area, then in most situations, becoming mobile and active is the preferred approach and is most likely to be effective in the majority of people. However, you have to keep in mind whether or not people start moving in this direction. That could happen because of reductions in activity based on isolation. It could happen based on increases in demand that go above their activity. So there's a lot of reasons to move from here to here, but we're also hopeful that there are a lot of reasons to move from here to here, move from mobile not active to mobile and active. So I'm going to take questions as soon as I just quickly say that there are upcoming presentations next week. Next week, I'll talk about pulmonary interventions some more that will clearly overlap with this presentation. I will talk on the 8th. I plan on talking about early mobility considerations and maybe some of the basics of mechanical ventilation for anyone interested. And on the 15th, I'll still be working from home. So yeah, on the 15th, I'll talk about long-term rehab considerations. They're all going to be at 12 noon Eastern time. They'll all be recorded and posted. And here is the link to where all these things will be linked from. So I'm going to stop my share and take a look at the chat area. Andrew Ball, regarding the Insta-famous PT putting out information on social media, I'm not sure who that is. Would you agree that the best thing for clinicians to teach the public in 60-second clip is humming in prone position? I mean, there are certainly some benefits to humming with regard to airways and nitrous oxide levels. So for people who are still healthy and able to do that, yeah, that's potentially. I'm being really cautious because there is a lot going on out there right now. And prone position, I mean, I'm not sure that's something for the public, because that's something really, I mean, hey, there's nothing wrong with telling people to lay prone, right? It's probably good for their hip flexors while they're sitting around at home all this time. So there's probably a lot of benefits to them going prone independent of their ventilation. So I think it depends on what you're saying, but the prone position in terms of improving ventilation is really something that ICU therapists are talking about for people who are getting that acute inflammatory lung condition and that acute respiratory distress syndrome, and they're trying to improve any way they can the ventilation perfusion matching. Under someone who's not in the hospital and who doesn't have major respiratory instability or ventilatory instability, then I don't know that the prone position would create a change that would be detectable pulmonary. Like, and anyone, even in the early phases, who's at home and just has some fever and some dry cough, I don't think if I put them prone, they would have an improvement in CO2 or breathing mechanics or oxygen levels. It doesn't mean they can't do it. It just means I don't think that it's going to change the course of their condition. The humming, on the other hand, because of the fact that there's a nitrous oxide, which is sort of a vasodilator and also anti-inflammatory for the airways, it actually is sort of a potentially helpful technique for a lot of people. And in fact, that's one of the reasons nasal breathing is encouraged with the Buteyko method, because it helps promote nitrous oxide. So prone is a good position in some people because it helps to improve ventilation perfusion matching. That the back of the lungs has generally has more airspace. So by putting them in that position, they get more ventilation to a broader area of the lung. That's one possible reason. So Trendelenburg and percussion. I think the Trendelenburg and percussion is really an airway question. So we'll talk about that if you're able to come next week or watch the recording from next week. That's airway clearance techniques. So I've been talking about airway clearance. Those techniques fall under airway clearance techniques. And if someone is having a lot of mucus, and if that mucus is in the posterior part of their lungs or the basal, the lower areas of the lungs, then those are the positions to use, but still not as good as just moving more. So if they're capable of moving more, that's what should be preferred. That's the preferred approach, would be moving more. Only if they're not able to move more would you encourage them to get prone and lay on their stomach for bronchial drainage or postural drainage or positional drainage, whatever you call it. I used to get yelled at when I was a new student working at Mass General ICUs. I called it positional drainage, and someone said, "We're not draining the positions, we're draining the bronchi." So I kind of am a little gun shy about what I call it. So I'll call it all three things: postural drainage, positional drainage, or bronchial drainage. All the same thing. And it's an airway clearance technique that may be needed under the circumstance of mucus and under the circumstance of not mobile enough to clear the airways otherwise. Great. So thank you. I'm going to say your name as Chitra, and I'm not sure I'm saying it properly, but if I'm not, I'm really sorry. Yeah, it's for anyone who's interested in basically learning more, right? I mean, a lot of people are sitting at home wondering what to do, and I'm a professor, so I'm sitting at home wondering what to do, and well, this is what I can do. Everyone's looking what they can do for their part. And if you're a physical therapist, you are licensed and you technically are legally able to provide these services. And if what you're lacking is the education, then I'm happy to help provide that. And my hope is that you would use it responsibly and that you would, not necessarily go out and do too many things on your own. I don't think people would let you just barge into an ICU and start doing stuff on your own. But I think that maybe you could help. A lot of these ICU treatments, when I worked in the ICU, I never did them alone. I was always with another therapist. So maybe you could be the second set of hands. if needed. Or maybe you could just be in the ER putting a pulse oximeter on people and saying your oxygen levels are low and you're breathing like a maniac. You need to get in there right away. Or your oxygen levels aren't great, but maybe if you breathe a little slower and deeper, they'd be improved, and you could work on that as a triage. So there's a lot of possibilities, a lot of possible things that I think if we, if people are prepared and think about it conscientiously, could, I don't know. I'd rather be prepared, because otherwise I'm sitting around just, I'm not going to say doing nothing. I'm still teaching my classes, but I do ramble. I'm rambling. The humming technique. Yeah, actually the humming technique, I can't do a great job explaining it, but I will. I'm going to share my screen real quick for anyone who wants to stick around and see this. Hoping my website, yep, still open. Here we go. So share screen, breathing clinic, share. So under services, I got this COVID-19, services, COVID-19. Way at the bottom, we had an individual come on Monday named Hannes, and he has this humming technique for vasodilation. And you can download that, and he has a description of it. And it basically is inhaling slowly. I can go for a long time, so I won't keep going. And you keep repeating that. And this is some of the information behind it. And I'm really, it's there, and here's a resource. I have no financial stake in this website. I'm not trying to drive people there for anything in particular. It's just a convenient place to put stuff. All right, that was the humming question, was the last one I got. So I'm going to stop the recording. You're all very, very welcome. And, if you have any suggestions, you can get in touch with me through the website. Here's my email. I'm on Facebook. I'm on Twitter. Anyone who has any questions or any suggestions, sort of making this up as I go. Me and some other people are trying to put together some of what I'm working on into a rapid release article from the cardiopulmonary section in the journal, the cardiopulmonary journal. I'm the editor of it, so I should be able to push that through pretty quickly. And as long as I have co-authors, I'm not afraid of violating any editor policies or anything. Thank you all. Enjoyed having you. Hope it wasn't too rushed.